Hi everyone, this is Miss Kimmy and we're going over the skeletal system today. I just wanted to make a brief, this is a very important chapter because this chapter, just like the muscular system chapter or our combined musculoskeletal system chapter, all of these chapters are going to become the foundations for you understanding kinesiology. You're going to see some terminology in today's chapter that is going to be further built upon when you reach kinesiology. And if you don't have this aspect of anatomy down packed, kinesiology only becomes harder. So make sure that you are doing your best to keep up with, at the very minimum, the skeletal system and the muscular system. So, bones are living tissues. We already knew that kind of going in with the past few chapters, but one very important aspect of the bones is that it has very extensive blood supply. There's 206 named bones. So we have bones that we don't quite have the name of yet, They look a little weird. We kind of just add them or group them to other things, but there are 206 named bones. And bones are the hardest tissues of the body. For instance, tooth enamel is officially the hardest. And osteology is, of course, the study of bones. Now, let's take a quick look at the word osteology, right? Osteo is always going to mean bones. Always. Ology, as we know, is just the study of. So when we see osteo, we know we're talking about bones. Whether that's a pathology or, a anatomical process, we're going to be talking about bones. Very simple steps in anatomy. We have bones and cartilage, as well as joints and ligaments. The physiology of the bones, right? So the function, right? FXN, or function, right? Is to support, protect, move, and really what's happening in that movement. No, my apologies. Really what's happening in that movement is that when you are, for instance, moving, right, I'm going to draw a quick picture of the bone right here, right, we're going to pretend that's a good looking bone. It's not, but let's say I have another bone joint here, right, and I have a muscle that attaches from here to here, right. This muscle is going to move the bones in that direction. Right, so when it says it pulls on and repositions the bones, that is what it's talking about, and you're going to learn a lot more about that in kinesiology and the muscular system. Now, another aspect of bones is that bones have, of course, they're a type of tissue, so they're going to have cells. And one of the important cells that the bone has and is going to produce is red blood cells, which occurs in the red bone marrow. Now, that is going to happen through a process known as hematopoiesis, right? We can, my apologies, we can relate that to the correspondence of blood. Now, fat storage, of course, also happens in bone, right? That's why we have yellow bone marrow. So you're going to see a picture later on of red bone marrow and yellow bone marrow and their functions in the bones itself, right? As well as another nice function is mineral storage. Now, bone tissue, we have different types of bone tissue. In this slide, we're going to be talking about compact bone. Bone is always going to be known as a connective tissue. Why? Because if I have one bone, it's going to help connect, right, to the rest of my body. So, for instance, if I have my hand, right, excuse my poor drawings, right, but if I have my hand right here, there has to be, my metatarsals to connect to my my metacarpals to connect to my carpals. That's going to connect, right, to my ulna radius, which is going to connect to my humerus, which is going to connect to my glenohumeral joint and the scapula, etc., right? It keeps connecting until it connects to the entirety of my body. Right, that is why it's considered a connective tissue. I know we can take apart a bone and just stare at the singular one bone and what problems that specific bone might have, but it's important to have this aspect present when we're looking at how movement occurs. Right now, we have two different types of bones. We have compact and spongy. Right, compact bone is going to be the hard bone. Right, it's a hard outer shell of the bone. It's there to serve a protective measure, and typically, right, spongy. It's not compact. There's holes. It looks like a sponge. That's why we gave it the name spongy. Isn't that a nice name? And they were named because of how, relative the density was, or how tightly the tissues are packed together, right? So the compact bone, everything's packed together. Very, very rough, right? Whereas with the spongy bone, things aren't really packed together that rough. You're going to see little porous openings upon the spongy bone, which are going to be. Now, of course, we have osteons, which are found inside the compact bone. They are these cylinder-shaped units with central canals, and they're interconnected with transverse canals. Now, the canals, we have the central canal being known as Haversian, and then Volkmann for the transverse canals. Do you need to know exactly every single canal? Absolutely not, but it is a helpful thing to be aware of, right? Because these canals are going to connect like blood tissues, right? Blood vessels, lymphatics, and nerves. Now, with spongy bone, it's a lot light and dense. It looks like a sponge, especially when you compare it to the compact bone. And this is going to have something known as trabeculae, which are thin strips in the spongy bone. And they're similar to like support braces in the building. So you're going to see you're going to see the porous, let's pretend this is the one. You're going to see the porous structure, and you might see like a line or two around it helping to support it. It's arranged to provide maximum strength and can rearrange in the direction that stress changes. So sometimes, for instance, let's say that this is a horrible picture of a bone, but we're going to use it. Let's say that this bone is going to jump up and down, up and down, up and down. Eventually, this part of the bone will become harder to be able to facilitate that movement. The red bone marrow, of course, is found in small and irregular cavities and is created by the trabeculae, which is going to form. Like, these are blood forming cells. They're going to form the actual blood that's going to go all over your body. Here's a little bit of the bone anatomy. So as you can see here, we have this right here. This is the epiphyseal line, which is, that kind of like supporting part of the bone that we were talking about a little bit earlier. This itself is spongy bone, and then here within these little holes, these are the red marrow cavities, which are going to help the red marrow, right, be able to like almost secrete blood out through this region. Here is the yellow bone marrow in the medullary cavity. A not so fun fact, but it's an interesting fact. A young person can die from having a fractured bone. So what does that mean? They fracture the bone, and the bone marrow goes into one of these lovely blood vessels and creates a fat embolism, and that person passes. Right? That is an occurrence that, of course, can occur. Now here, as you can see, like these nice edges, right, that is our compact bone. And over here, we're seeing right here a more close-up view of the compact and the spongy bone. So this is where we're seeing, right, the osteon, right, where the osteon is like holding on to blood vessels and doing everything it can. And then these nice little holes are going to be the canals, right? Now that one's the central Haversian, and I don't see the other one, but typically some of us will call them the central canals. That's where you're going to see a lot of blood vessels popping up. And here, in a nice little region, you're seeing an osteocyte. This is a single bone cell. And this is showing you the difference between how compact bone looks like under a microscope versus spongy bone. Right, spongy bone, of course, being more porous. Now, over here is the periosteum. The periosteum is a bit of like, it is protecting the lining of the bone. So the compact bone is the inner lining, but the periosteum is more so the outer lining, protecting that inner lining. And what am I missing? Okay, so very, very cool. A couple things you need to know about this specific part of the slide. Apologies. You have the epiphysis right here, diaphysis, and epiphysis, right? This is telling you regions of the bones. So the epiphysis are going to be most likely to connect to a joint, and the diaphysis is known as the bone shaft, right? It's very important to note this because this is what's going to play a bigger part, again, way later on, especially when we're thinking about like, okay, a muscle can connect from over here straight to the diaphysis. What is, this muscle, this part of the muscle going to be known as, right? And then, of course, you're going to be like, oh, that's going to be an insertion because it's moving the bone. But that is, again, of course, for future reference. Now, these are the bone cells, specifically the certain types of cells. We have osteoblasts, which is going to, boom, you have another bone cell. And then you have osteocytes, which are known as mature bone cells. Osteocytes are kind of just chilling in the sense of, they're roaming around the bone, making sure things are okay, and then they'll pass along, harden, and etc. Then you have your osteoclasts, which are the bone destroying cells. I can't have too much bone. So there's going to be a relationship between the osteocytes and the osteoblasts right there. And that relationship is about keeping things, we're not making too much bone, but we're also not making too little bone, right? If I make too little bone, then I of course can run into osteoporosis. I can run into different types of arthritis. I can run into many problems. But if I have too much bone, I can run into equally like as much problems just because I have too much. This is what ossification is, right? Ossification is the process of bone tissue development by osteoblasts, right? There's a big boom of this when you are born, right? So fetal development, you come out of your mother's womb, your head is almost like, it's actually considered a membrane. That beautiful skull of yours was at one point very malleable so that you can go through your mother's birth canal. And what starts to happen is that it osteophies, right? It ossifies. And then so once it ossifies, that process is now known as ossification, right? So that is developed by the osteoblasts, begins during fetal development, and continues through adulthood and even for bone repair and remodeling. There are different types, right? We have intramembranous ossification, right? This is bone development from membranes, which is specifically what we were talking about a little bit earlier, about how when we're born, we have more of a membrane for a skull than just a skull. That's why there's times where you can feel a soft spot on a baby's head. That's what that means. Now, we also have an endocrinal ossification. This is bone development specifically just from cartilage. Now, bone remodeling is the process of bone destruction by the osteoclasts and bone formation by the osteoblasts, right? So this is going to happen like throughout your life, especially in your adolescence to teen years when you're constantly growing. Begins after bone growth completes throughout life, yeah. So pretty much you're going to see a bit of this. We have what are known as growth plates. Once our growth plates they're in our bone, and they're going to help us grow to the height that we are corresponding to. Once we achieve that height, typically what happens is that now whenever your bones are going to remodel themselves, let's say I walked way too much and I have minor fractures on my feet, that is when this process of bone remodeling takes completely over, right? In other situations, it has been shown that like the growth plate will actually help in that remodeling process, but once we are done growing, the growth plate has nothing to do with it. Now, there are two phases of formation and destruction, or otherwise known as reabsorption, because nothing's really destroyed. These occur at the same rate so that the density is constant in a healthy bone, right? Especially as you're growing or as you're aging, your bone density starts to change, and your body, specifically your skeletal system, is trying to make sure that that change is consistent. Because if I suddenly lose a lot of bone density today, tomorrow I will probably have a fracture. So when that's happening, right, whether that's happening because I'm aging or my gender or my physical activity levels, I should be aware that this is a process known as bone remodeling, one. Two, and this is a process that everyone around me is experiencing because of the skeletal system. So some people use this information to their advantage. For instance, my husband's a fighter. What does that have to do with anything, Miss Kimmy? Well, my husband is crazy in the sense of he has literally broken his bones in his fists to remodel and reshape them to have a bigger impact when he hits someone. How does that happen? Through bone remodeling. So again, I can have the example with my husband. We're going to pretend this is the fist, right? And this is the tree. He hits the tree, makes impact. This is going to make some impact. So the bone recognizes, oh, wow, he's probably going to keep doing this. So it starts to create this ossified layer of bone to protect this area. Now, of course, it's not going to look exactly like that. It's just the bone is going to become thicker in this area. Why? Because it doesn't want to break again. But, the body doesn't necessarily understand, like, oh, this is just for, like, competitive purposes. Like, no, like, the body actually thinks that in hardening this way, he will be less likely to fracture his fist. And so, because he is less likely to fracture his fist, the more he does it. And then there becomes this cycle of bone remodeling. That is why physical activity levels, right, are always going to be considered in that phase of formation, reformation. Now, of course, some other things to be aware of: certain medications and hormones can affect bone remodeling. So, for instance, your thyroid hormone plays a big part in calcium regulation. Me personally, I have thyroid problems. That makes me a little bit more at risk to develop things like arthritis. I have arthritis, so I'm not surprised. But this is a bit of a fact that people aren't aware of, right? Your hormones do help regulate your skeletal system. Now, we have different classifications for bones. These are super easy, guys. Don't overthink it. If it's long and it looks long, guess what? It's a long bone. It's longer than it is wider. If it's short and it looks like a little cube, right, it's a short bone. Right, they're small and cubed. They typically have different surfaces that the joints will attach to, and you can move them. If it's flat, it's a flat bone. Broad, flat surface, right? If it's irregular, it looks odd. You can't really it doesn't really look like a cube. It doesn't really look like anything. It's kind of just weird. Looks like a dot or something, right? It's irregular. So it's odd shaped. Doesn't fit well in other shape size categories. And of course, if it's small and round and found around tendons or embedded in tendons, it's going to be known as a sesamoid. So here is a little bit more of what this looks like, right? So you can see this long bone, that's the humerus, right? This irregular bone doesn't look like any other bone that I know of unless they're in the vertebrae, right? This is the vertebrae. Flat bone, you see, very broad, taking up all this real estate. This is the sternum, right? This is going to be known as the manubrium. This right here is body of the sternum, and that is the xiphoid process. right? Here we have the sesamoid in the bone, right? So this is going to be right here. You can see it right there, right? It looks like a little butt on your thumb, but it helps you actually articulate your thumb. Here's a short bone. This is in the tarsal, specifically, right? Ankle. You want to think about the ankle when you hear tarsal. Carpal, you want to think about the wrist, right? So tarsal, that is a short bone in the tarsal, right? Another short bone that you would have is, for instance, in a carpal bone in the carpals. Now, with long bone anatomy, we talked a little bit about the diaphysis, the periosteum, and we're going to go a little bit deeper. The diaphysis is just the shaft of the bone. Here it's going to describe it as a cylindrical shaft, but you just got to remember it's the shaft. It's the long part of the bone. Now, the periosteum is a fibrous sheath, right? That's going to be around the diaphysis. Why? Because it needs to protect that area. It's dense. It's also going to contain blood and lymph and nerves as well as osteoblasts because it's trying its best to make sure this region of the body or this specific bone has all of the supplies it needs to continue to remodel and reshape if it needs to. It doesn't always need to, in the sense of like, we are in a constant state of remodeling, but we're not like going crazy with it. What do I mean by that? So for instance, if I like walk for long distances, yes, there could be a change in my bones. So my body is going to be in a constant state of remodeling. Now the change is not a drastic change. That's what I'm talking about. Now, why is it not a drastic change? Because of the periosteum. Right, the periosteum is holding on to anything that bone might need in the future. So it's never going to be, ideally, it wouldn't be a huge drastic change that my bones have to go through all the time. Now, a huge drastic change that my bones would have to go through is now pathology and specifically a fracture, right? If I have a fracture, my bones are going to be working overtime to rebuild, remodel, and, do what it has to do to keep me healthy. Right, but this is just, we're talking everyday occurrences. So here we also have what is known as the interosseous membrane. So here we have osseo again, right? So in bone membrane, right, which is a type of ligament. These are extensions of the periosteum in the forearm and like bones. Very simple, it's just there's a little bit more steps in certain parts. Now, the medullary cavity, this is a hollow space in the diaphysis, and this is where the red and yellow bone marrow is going to be. And it's going to be lined with the endosteum, which is going to contain osteoclasts. Now, the epiphysis are the ends of that bone. Typically long bones. We're not going to count the carpals in this because there is no, they kind of look oddly shaped, so it's like, it would be weird if we were, epiphysis, diaphysis, epiphysis, we can't because it's articulating over multiple surfaces. Whereas with long bones, we don't have that same situation. Now, the articular cartilage, of course, is going to cover those epiphyses. So the epiphysis is where the bone is eventually going to articulate with other bones. What does that mean? That's where the joints start to happen, right? So because that's where the joint starts to happen, we need something to protect it so that the joint isn't just grinding on another bone. It would be very painful, and that does happen with people. For instance, most cases of arthritis are not necessarily due to lack of lubricant or lack of this. Well, and by lubricant, I mean synovial fluid. Most of the time it's due because of, a disintegration of cartilage, specifically the articular cartilage. Now, the articular cartilage is going to be consistent of hyaline cartilage, and the periosteum is not present in this area. Here we have the epiphyseal plate. This is the cartilage plate near the ends of growing bones, and this allows your bones, of course, to increase. This is also called the growth plate. We talked about it earlier, which is a little very different from the remodeling. My apologies. Now, the epiphyseal line is an ossified line left after long bone growth. in the epiphyseal plate, right? So what does that mean? I'm not gonna see a picture of it, but for instance, the epiphyseal line is what the epiphyseal plate becomes later, right? It's gonna stay there hardened. It's not gonna go through its same properties over and over again because it's already finished growing. That's why, I'm not gonna grow more than I am. I am 5'3" and I'm gonna stay 5'3" probably for the rest of my life. I might shrink a little bit because I could lose cartilage and I can lose bone density and I can lose all of these things and I might shrink a little bit, but I will not get taller than this by natural means. Now, if I were, for instance, a child and I was 4'2", I would definitely have, a chance to grow because of my epiphyseal plate. Now, be aware, right? The bones are already telling you where everything is because here we know the epiphysis is at the end of the long bone. The epiphyseal plate is going to be in that region. So the epiphyseal line, of course, is also in that region. This is what we call like anatomical mapping, using the terms to tell us where things are, even if we're not so sure. So in the MBLEX, it's important to be aware of these words so that you're constantly, that way nobody can really like tell you don't know what's up because all you have to do is look at the word. What are the root words? What are the suffixes? What are the prefixes? What are you talking about? Okay, cool. I know what you're talking about. Then I have an appropriate answer for you. And that's a big chunk of passing the MBLEX if that's something that you're a little nervous about. Now we have two divisions of the skeleton, right? This is the entire skeleton, right? This is a little different than everything else we were talking about in the sense of like we were talking about like these are parts of the bones. Like, no, we are talking about the entire skeleton. Right, now we have one division known as the axial skeleton. I like to talk about the planet a little bit because we know our planet rotates on an axis, right? And because our planet rotates on an axis, we know closer you are to that axis, the more gravity would affect you. This is more so theoretical physics, but it's a very interesting perspective. Now that we know that our planet rotates on an axis, what makes you think that we are different? We're gonna see, for instance, our axial skeleton, like we can rotate if we want. Like, I'm gonna pretend this is a good drawing, but it's not. Right? Apologies for my horrible drawing, but for instance, right here, the skull, the vertebral column, the sacrum, the ribs, that is the same as the axis the earth spins on in the sense of like these two things are very similar. Why? Because it's kind of like the center of us, our center of gravity. Things are pulled towards the axis of the earth. We turn on our axial skeleton. So there are 80 named bones located along the central axis. But when we hear the skull, the vertebral column, the sternum, the ribs, right? These are going to be known as like landmarks. So for instance, like the skull, we all know it's the cranium, it's our head. Vertebral column should be our spine, sternum, chest, ribs, etc. However, these names are going to have even more names to them in the future. Now, the appendicular skeleton is 126 named bones, and appendicular, you want to see that word, and you want to immediately think about your appendages. Right? Because these words are tied together. Now, that appendicular skeleton has much more moving parts. Why? Because it's going to move much more than the axial will. So that's going to include, of course, your shoulder and your pelvic girdle, as well as your upper and lower extremities. So, appendages. We're going to see in the next slide all of those beautiful pictures. So here we have the skull, which if I start looking at it apart, right, this is going to be my maxilla, this is going to be my mandible, that's going to be my zygomatic bone, frontal, parietal, and you start getting more into like what it is, but this is just a region. So in this situation, we can call it a skull. Be aware with that word. When people ask you for a region, they're asking you for the general location. They're not asking you for a specified location. That sometimes is a question that pops up on the NBLEX that people get wrong, because yes, you were right to think about when they talked about the sternum and they're asking you what is a central region of the axioskeleton. And the options are manubrium, sternum, humerus, and maybe let's say your femur, right? Of course, if you know the word manubrium and you know that the manubrium is this part of the sternum, you might say that, but that's not what they're looking for, because they asked for the region, which is the entirety of the sternum. Just a FYI. Now, for your regions of your skeletal system, of course, you have in the axial skeleton, we already went over it. We have the skull, the sternum, the ribs, the vertebral column, and the sacrum, as well as the coccyx. Coccyx is this little bone right here, sacrum right there. However, in our appendicular skeleton, we are going to include joints in this area that are responsible for movement. So for instance, a question I'll get is, Ms. Kimmy, why is the clavicle and the scapula not a part of the axial region of the skeletal system? I'm like, it's not, because lift up your arm, right? If I lift up my arm, if he lifts up his arm, the first things that are going to move are the clavicle and the scapula. So because it's playing that big crucial role on movement, it's not going to be part of the axial skeleton. Now the same thing goes for your pelvis. Move your leg and you will feel your pelvis react with that. So be aware of all of these tiny semantics that they seem very easy, but if you don't have a very fine-tuned understanding of it, people can ask you questions and you can get it wrong, even if you knew the answer. Because you picked the right answer, but you didn't pick the most right answer. Now, here, for instance, right, we should know axial skeleton, skull, sternum, ribs, sacrum, coccyx, very easy. Appendicular skeleton, everything else. Clavicle, scapula, humerus, radius, ulna, carpals, metacarpals, phalanges, femur, patella, tibia, fibula, tarsals, metatarsals, phalanges, and then, of course, pelvis. Here is the posterior view of the regions of the skeleton, where you can see that the scapula is in fact part of the appendicular region, right? But everything stays relatively the same. We can see a little bit more in the sense of, like, you can see how the coccyx really is our little tailbone. It's my favorite. But that's one of the things to be aware of. Our sacrum, our beautiful sacrum, of course, always part of the axial region. Pelvis, part of the appendicular region. Now, a joint is simply going to be where two or more bones join, right? Take that T, you have joint. Very cute, right? And these are also going to be known as articulations and arthrosis. This word, be aware, right, that it's already told you. Arthrosis can also be called a joint. It's going to be helpful in pathology. Anyway, every bone articulates with another bone except for the hyoid. Now, the hyoid is going to have a very interesting function. Hyoid, of course, is going to protect the thyroid, which is not located in the thigh. It's located in the throat, right? And these are, of course, going to be classified by their function. We have fibrous, which is conducted by dense fibrous connective tissue. Sutures are a big example. The sutures are, of course, going to be found in your skull. We're going to pretend this is a top view of the skull, and you see this right here. That is the suture, right? The suture is that fibrous dense connective tissue. Now, cartilaginous is typically joined by a cartilage or a fibrocartilage or a hyaline cartilage, and a big example is the pelvis. Excuse my drawing of a pelvis right now. It's not the best drawing, right? But right here, this is going to be your pubic symphysis. Your pubic symphysis is a cartilaginous joint, so they're joined together in that region. And now synovial joints are going to be joined by a joint capsule, and that joint capsule is going to have my favorite thing in the world, synovial fluid. And this is the most common and movable type of joint. So for instance, right, we think of a ball and socket joint, right, in there you're going to have that synovial membrane. So here are the classifications. Here, this is showing you the humerus and then the olecranon process of the ulna. Right here, it's showing, right, beautiful humerus. Right, so if that's my humerus, and then this is the olecranon process of the ulna, this is my elbow. Now, in having that, here I can see the synovial membrane, right, which is going to give me all the synovial fluid I need. Here are the articular cartilage in green. That is protecting, making sure that I'm not literally like grating bone as I'm moving. And then the synovial cavity is, of course, is going to help with the protection of synovial fluid. Here I have a fibrous capsule. Fibrous capsule and the fat pad are going to help protect that region of the body. Here, just as we were talking about, that is the pubic symphysis, which is connecting my pelvis together in form of cartilage. And then there we have a suture, which is, of course, fibrous. Now, there are functional classifications of joints. We have synarthrotic, amphiarthrotic, diarthrotic, right? Or SAD, right? This is from least movable to most movable. It's just SAD. Synarthrotic movement is not permitted or very limited, right? They resemble the fibrous joints. Whereas amphiarthrotic, it's slightly movable. That's more so cartilaginous joints. And then diarthrotic is freely movable, which is synovial. But, it's sad that not all joints are movable. That's something you could say. Try your best to remember this. Now, on the outer region of the synovial joint anatomy, if we, of course, have the joint capsule, the ligament, the articular cartilage, right? The joint capsule is that dense tissue that surrounds the joint. This is serving as a protective barrier. The ligament is going to unite articulating bones, so it's going to keep them together, make sure everyone is, in the correct position. The articular cartilage is going to cover the surfaces of the bones, decreasing friction, right? And also increasing short shock absorption. So if I just, jump in something, it's not going to be completely painful for me. Why? Because I have that articular cartilage covering the surface of where the joint is supposed to go. Finally, I have the labrum, which is a fibrocartilaginous ring around the edge of the articular cartilage. This is to keep it in place, and we can see it in the shoulder and hip. In the inner region, we have the joint cavity. This is an inner region of the joint, as well as the synovial membrane, which is going to line the joint cavity and secrete fluid. This right here is our main. That is big. Why? Because this, as massage therapist, if you learn how to manipulate people's synovial membrane and manipulate for them to secrete more synovial fluid, most of the time they tend to report feeling way better, especially if this is a patient dealing with arthritis. Now, for our synovial fluid, of course, that is going to fill the joint cavity and decreases the friction during movement. It, of course, is going to lubricate that joint cavity and provide nourishment as well as shock absorption. So this is a helpful process, especially, could you imagine if you have a lot of friction in that joint cavity? That lubrication is going to be very helpful for pain relief for that patient. Here is the structure itself. So just wanted to remind everyone, right, we have periosteum. The periosteum, of course, is doing what? Providing blood and lymph and all the things that the bone may potentially need. Then you have the bone itself right here and the blood vessels, right? The nerve, of course, is going to innervate the muscle, tell it when to move. Joint capsule here is going to, contain that synovial fluid and not necessarily contain it, but hold on to it. Whereas the joint cavity itself is going to contain the synovial fluid. So you see how like this joint capsule, if something horrible were to happen, all that synovial fluid would just slip out. That's a little bit of what the joint capsule is trying to prevent from happening. Then, of course, we have this right here, this beautiful ring known as the articular cartilage, smooth, trying its best not to hurt anybody. And then the synovial membrane itself, which is my best friend. We have accessory structures, right? So, for instance, our accessory structures are going to help with the function of what it is that we need to do, meaning it's going to fill spaces during movement, for example, in the knee. We have the bursa. The bursa is a flattened sac between ligaments and tendons and bone, and this reduces friction. Now, if I have bursitis, that is an inflammation of that sac, and it's going to create even more friction. See how pathologies work? Not great. Now, the synovial sheath is an elongated bursa around tendons, and this is going to increase gliding capacity. Of course, our meniscus helps irregularly shaped bones fit together. The biggest example is the knee and mandible. Here is where we can see the subdeltoid bursa and the subacromial bursa. Of course, I'm going to have one. This is a protective factor. Not only is it a protective factor, it's trying to make being a joint as smooth as possible. So of course I'm going to have one for this part of the process and this part of the process. This needs to support the acromion process. It has to. And then this is of course going to support, the head of the humerus. It needs to. If it doesn't, it's going to be a very painful experience. Now, where an inflammation begins to occur, this is going to be a very painful experience for this patient. Why? Because there's a potentiality where this acromion process can begin to lift, and then you would need that would include further complications in the healing process. Now, we have different types of synovial joints. We have what is known as uniaxial, right, which is they move on one axis and found in one place. For instance, this is where I want to say things start really picking up with the joints, and this is going to be the most useful for kinesiology. So the hinge joint is a big example for the elbow and the ankle, right? It's going to help allow for extension and flexion. Right there. It's going to go like that. Flexing, and it's also going to extend. Right now, it is a convex surface, so it's going to fit into a concave surface, creating the movement, making it possible. Now for the pivot joint, this is a hinged notched surface that fits into a projection and allows rotation. For instance, the first and second cervical vertebrae. Here are the biaxial joints. This is two or more axes or planes of movement that this joint can reach. For instance, we have the saddle joint, which is concave. It looks like a saddle if you think about it, right? And it fits into a convex surface. So concave typically is going to fit into convex. Right? And that's going to allow for flexion, extension, abduction, adduction, opposition, reposition, and circumduction. Right? So for example, your thumb. That is a horrible looking thumb, but we're going to pretend this is a thumb. Right? My thumb right now I'm making little circles with my thumb. Now, condyloid or ellipsoidal is an oval-shaped surface that fits into a depression or a socket, which is going to allow for flexion, extension, abduction, and adduction. For instance, like if you start to... My best example of this movement is whipping up something delicious in the kitchen and you're stirring a bowl. Now, multi-axial, we're talking about 3 axes, 3 planes. This is way more movement, and we're thinking the gliding joint, because this is going to be interactions across flat bony surfaces, and it pretty much allows for all. It's limited, but a lot of movement can happen with a gliding joint. Whereas with the ball and socket, of course, you have a ball-shaped bone fitting into that socket-shaped bone, and it's going to allow for all movements, and most movable joints are going to be a ball and socket. For instance, your shoulder, that's a ball and socket joint. I can like helicopter my shoulder and do everything I want to do. Here are the specific joints and their location. I want to start here with F. As you can see, we talked about that gliding joint. Now I can do, I used to take belly dancing as a kid. I still do belly dancing. Now my spine isn't supposed to be doing some things that it's totally doing. And the reason why, it's because of that gliding joint, right? So when you see someone do like a snake pose or, body rolls, all of that stuff, and they're moving that way, what's allowing the movement is that gliding joint. Now, on a minor note, for instance, anyone who just loves to dance is constantly using that gliding joint. But even if you walk in a strange way, you're using that gliding joint. If I stop to bend down, I'm using that gliding joint. Why? Because, and so on and so forth. Like, you can see how we have very complex movements such as dancing using that gliding joint, and then, very simple movements such as walking, also using the gliding joint. Now from F, we're going to go to D. Here is the condyloid or ellipsoidal joint, right, which is right there in the neck. It's going to create a little bit. A nice exercise to do for yourself is to hold this region of your head and move around and see how that makes you feel. Very nice. Very nice little head bob I got going on. Right here in B, we have the pivot. This is going to help pivot and tell me, no, I don't want to do something today, right? So if I shake my head, it's a good example. At E, we have, of course, the ball and socket joint in the hip. Of course, you can move that in whichever direction you want. In C, we have a saddle joint for the wrist, right, or the joint of the thumb. Right, but regardless, move your wrist around, move your thumb around. You can see how complex that movement is. Then, of course, E we have again in the shoulder. And finally, our hinge joint right there in the elbow. That helps me flex and do everything I want to do. Now, with the synovial joint movement, it's important to be aware of, certain things that we may not be aware of, but we all definitely have heard at some point in our lives, right? So a synovial joint movement is just going to happen whenever joints muscles are going to contract. And you might hear this thing called crepitus. So sometimes when I'm in class, when I'm teaching, and I tell everybody get up, get up, get up, I can hear throughout the whole class. Right, and that is a perfect sign, like a perfect sign or example of crepitus, which is this painless noise during movement. It's a cracking, it's a creaking, it's a grating, it's a popping. And our explanation for why that happens is that synovial fluid can accumulate nitrogen while joints are not being used. And so when you move around, you're popping those nitrogen bubbles, and that's what's making that noise. Very cool. That's what you are experiencing when you're getting an adjustment at the chiropractor. Now, for flexion and extension, this is bending at the joint so that the angle between the bones increase. So you want to think about, my horrible drawings, oh my god. You want to think about an acute angle for flexion, whereas for extension, you want to think a little bit more obtuse, right? Obtuse angle for extension. Right, and then hyperextension, of course, we're talking about like if the bone, let's say the bone flexes like this and you're going completely like that, that is unnatural, that is overextending beyond what is normally the straightened position. So be aware that, there are some joints that permit hyperextension. For instance, a joint that can permit hyperextension are the joints in your pelvis when you start doing things like the splits. Now there's people that will tell you like the splits are horrible to do for your body, like don't do it, and then there's people that tell you that they're great. So I don't know where you guys fall on that. I'm not going to insert my opinion here. I mean, I don't really think it's relevant, but some people would consider that a hyperextension. So here we're seeing the extension and flexion by opening and closing the wrist. And then we have extension and flexion through dorsiflexion, plantar flexion. Here is, flexion and extension of the knee, flexion and extension of the hip, flexion and extension of the knee, flexion and extension of the head, flexion and extension of the arm, and so on and so forth. Now, for abduction, you want to think of an alien. Gotta take someone away because it's moving away from the midline. Right, horizontal abduction, right, it's happening horizontal, right, so your shoulder, your hip moves away from the midline. And then radial deviation is also known as wrist abduction. Your hand is going to move away from the midline in anatomic position. For adduction, you see that beautiful word, adding, we're adding to the midline, so movement goes towards the midline. Horizontal, again, similar like how it was with abduction. That means your shoulder, your hip is moving towards the midline. Opposition, your thumb moves towards other fingers of the same hand. Reposition, it returns back to its position. Right, so opposition, closing my thumb into my hand, reposition, my thumb returns. Of course, there is ulnar deviation, which is a type of wrist adduction where the hand moves towards the midline in an anatomical position. So here we can see abduction is, these pictures are a little hard to see, right? But abduction, you want to think about that alien abducting, right? It's going away from the body. And then adduction is adding to the body, right? So again, this is abduction over here. And then when he swings back this way, that is adduction. Same thing. Abduction, adduction, abduction, adduction. Right, horizontal abduction. Right, again, little alien friend. Abducting the arms. Here's a nice picture of opposition. And then, of course, this is abduction. You can see the hand moving away. And then abduction, the hand is moving too. Circumduction, of course, this one is really easy. Circle, go circular or conical, right? So typically we're talking about circular movements. You can do this with your legs or with your arms. Rotation, this is when the bone pivots around its central axis. We have left and right rotation, the direction of rotation in the central axis. There's lateral medial rotation, which is the rotation in the appendicular skeleton. So left, right is axial, medial, lateral, appendicular. Up, downward, typically talking about the scapular movements and defined by the direction of the glenoid cavity. So here we have rotation in simply saying no, in just swaying back and forth, and also rotating your hand to and fro. Right, here is a bit of a rotation with the feet, a little bit of another angle so you guys can see it. And then this one is beautiful. So this is where some people get mistaken because they don't really see the scapula rotating, but this is also rotation, right? So my scapula moves in this region to accommodate this arm, and then it returns back once I'm, neutral. Supination, of course, we have the word supine, which is face up, right? Lateral rotation, right? Supination's palms up, very simple. Pronation's palms down, right? Very, very simple. So this says forearm bare bones crossed to form an X. If we were to, for instance, look at our bones during an x-ray, they would be crisscrossed over each other when we are in pronation. Plantar and dorsiflexion, right? Plantar flexion, of course, we're putting, gas to the pedal or pedal to the gas, one or the other. And this is going to move inferiorly, so it's going to move below towards the plantar surface of the foot. So when I do this, I recommend all of you do this. I'm going to feel this part of my foot actually flex, and that's why it's called plantar flexion. It's because the plantar part of your foot is flexing. Now with dorsiflexion, it's the movement of the ankle, so the foot moves superiorly. Now this is called dorsiflexion because right here and probably right here, I'm going to flex, right? Dorsi is going to mean back usually, right? So for instance, if you didn't know this and now you do, right? The dorsal fin is that back fin that like dolphins have and stuff. This is my nice picture of a dolphin, but whatever, right? So that dorsiflexion is you're flexing the back part of your foot leg. Here's inversion and eversion. As you can see, inversion, you're turning your foot in, so that the bottom faces the midline, and then eversion, you're turning out, right? Now, the foot has greater range of inversion than it does eversion, so be aware of that. Elevation, depression, when my jaw drops, it's a depression movement, right? So depression, and then elevation is me maybe clenching my jaw. Right, depression, elevation in the scapula is a little bit easier to recognize, right? When I'm elevated, I'm bringing my shoulders up, or my shoulders up, and if I'm depressed, I'm bringing them down. Retraction and protraction, I don't necessarily recommend to do this, especially if you have a sensitive jaw, right? But protraction, I'm going to move my jaw forward, or, I can move my scapula forward. And retraction, I can move them back. Here you can see them, right? Protraction, protracting my back. Retraction, bringing it closer together. Excursion or side-to-side movements of the mandible, also known as a lateral deviation. Here are some pathologies and inquiries of the skeletal system. I highly recommend, I sent a PowerPoint. I highly recommend checking out the PowerPoint, of course. We talked about some of these, but not all of these. Do your due diligence just to make sure. Have a good one, guys.